All right. Hello, CASW members, and welcome to another webinar with the Canadian Association of Social Workers. I'm seeing a bunch of you tuning in right now. You must have gotten our emails, so bear with me as we let a couple of those people join us, and then I will do some housekeeping notes for all of you who may be new to our platform. So for anyone who is joining us today from wherever you are, you're at, my name is Alexandra Zanis. I am the Social Policy and Communications Coordinator here at the Canadian Association of Social Workers. We're so happy you're joining us for another couple-hour webinar and continuing education opportunity. Hello. We are seeing chat come in. Please, for anyone who has yet to find the chat function, it is on the bottom hand of your widget screen. So something that I have done it strategically, as I have grouped all of your things together in one kind of messy little spot on your screen. I've done this to hopefully show you that you can move it around and you can make this platform everything you need for your own viewing needs. So for me, I get all that stuff in the middle and I take a couple minutes. So take a couple minutes now and make it what's best for your viewing needs. So for me, I like to make the presenters bigger and the slides bigger and keep my chat function at the bottom. One thing I will say is that I'm going to be on the back end moderating this webinar as we normally do. So any chat questions you have, type them throughout the presentation. We are so lucky today to be joined by 4 webinar presenters. So there's lots of time to answer your questions. So ask them throughout the presentation. Don't worry about holding on to them. Ask them throughout the presentation and we'll compile them for a hopeful, Q&A session where you feel like your questions and answers are answered and heard. This is part 1 of a 2-part webinar series. So thank you for joining us for part 1. And then if you're tuning in later, thank you for joining us before we do part 2. So make sure you put it in your calendars that we've got a part 2 coming up. And then I think one of the last things I have to mention is if you need your certificate of attendance, that is on the bottom. I believe it's titled Your Course Completion Tracker. So this webinar is 2 hours long, meaning that you're required to view 75 minutes of the presentation to be eligible for that certificate. So I know for many people, we usually say 40 minutes because they're an hour-long webinars, but today it's 75. So if you're struggling to access your certificate of attendance, it's likely because you haven't reached the required viewing minutes. But as always, you can let us know if you're struggling to get that certificate, and we will help you out with it if you need. So with all that being said, and I see that we have quite a few people that are joining us, so I think that we're probably at our max here. Please, again, use the question and answer box. We will send you messages as the presentation goes to answer your questions that you may have, so don't hesitate to type it in those boxes. And we are so lucky to be joined by the Fraser Health. Is it Authority, guys, or do I always get that wrong?
Yeah. Authority, Fraser Health Authority.
Yeah.
Fraser Health Authority. So we are doing advanced care planning today, something for social workers who work in any sector. So we're excited to have you guys from whatever sector of social work you find yourself in. Advanced care planning, as we are starting to realize with the COVID pandemic, has become even more important and even more vital. So at the Canadian Association of Social Workers is just very grateful for this opportunity and to have these incredible presenters. So with all that being said, I'm going to pass it over to them. I am on the back end if you need me. And thank you so much, Fraser Health Authority.
Yeah, thank you so much for inviting us. It really is an honor to be here with everyone today, and pleased that the team of social workers that work here in Fraser Health and Advanced Care Planning are with us. And we can introduce ourselves when we are speaking, but certainly I think when it was advertised, a little information about us was sent out. But let me just start by saying that I'm Carrie, and I'm the lead for Advanced Care Planning in Fraser Health. I've been around a long time, and pleased that we have such a great team now that has joined us in Fraser Health about a year and a half ago. But I really wanted to start with, the title of our presentation we talked a lot about, and we thought, this is definitely an area that is important in our work that we do as social workers, but it's also important for ourselves. It's important for the organizations in which we work, and it's really important for our professional organizations. And so we're hoping that today we can really touch on all of those areas, knowing that this advanced care planning and planning in advance for our future healthcare is something that affects certainly every area of our lives. I wanted to ask Laura, who is one of the social workers with Advanced Care Planning, to do a bit of a territorial recognition before we begin.
Thank you, Carrie. I guess this is probably an appropriate time to do a brief introduction of myself as well. As Carrie said, I'm Laura Gaspard. I'm one of the social workers on the Fraser Health Advanced Care Planning team. So to start off, I'd like to invite all of you to reflect on the spaces in which you work, live, and play. Think about what makes these spaces special and close to your heart, be that how much green you have there, or maybe there's open skies, lots of water, or I know some areas of Canada, we've got some fantastic trees that are changing colors. Just invite you to reflect on that. And on behalf of our team and the people attending the presentation today, I'd like to acknowledge and extend gratitude to the First Peoples across Turtle Island from the past, present, and future for their stewardship and taking care of all of these spaces for us. Without their care of the land, we'd be living in a very different environment. My team hails from the traditional unceded shared territories of the Coast Salish peoples. I'm personally speaking to you from the traditional unceded territory of Tsawwassen First Nation. Although we may take these spaces for granted, we are grateful to call these spaces home for ourselves and for our families. So thank you.
Thank you, Laura. You always do such a lovely job at that. Thank you so much. And I'm here. We're all obviously in different places doing virtual things these days. So I'm on the Katzie First Nation and Kwantlen. Oops, did I go too far? No, I didn't. Oh, yes, I did. Let's go back one. There we go. Oh, there. I don't know. There, I've got a bit of delay. Sorry there. So, and the other thing that we really wanted to talk about just right up front is, that old saying that there is a bit of an elephant in the room these days, and we also want to recognize that these are challenging times for all of us, personally and professionally, and certainly for the people that we support out there with a global pandemic. And I am going to also ask Randy to step in here and to give us a few minutes talk around the elephant in the room.
Yeah, thanks so much, Carrie. My name is Randy Gosen. I'm a social worker on the Advanced Care Planning team here with Fraser Health. Carrie had done this single-handedly for about 15 years, and then she was joined by us just about a year ago. So we're all thrilled to have the opportunity to work with her and today to present to you guys. This elephant in the room has really impacted everyone, not just in Canada, but globally. Typically, when we think of advanced care planning, we often think of palliative clients, people in the ICU, people in the emergency room who are clinging to life. COVID-19 has really pushed to the forefront the possibility that any one of us could find ourselves in a position whereby we are unable to make healthcare decisions for ourselves, and someone might be called upon to make healthcare decisions for us. I personally have a friend who traveled. She was an otherwise healthy individual. She traveled, came down with COVID-19, and spent more than 3 weeks in ICU, intubated, and her spouse was cast into a position where he had to make many healthcare decisions on her behalf. And they had no conversations, no discussion about this ahead of time. So this really just drove to the forefront the difficult position, the challenging position that he was in. First of all, having his spouse in that position, but then having to make decisions on her behalf that he was really, really ill prepared to make. So COVID really is the elephant in the room, and we do want to mention this up front. Advanced care planning can be a tricky topic to discuss. Talking about our own mortality isn't always comfortable. So we just want to be sensitive to that, and both for ourselves as professionals, as mortal beings ourselves.
Thanks, Randy. And I'm sure that many people have stories of their friends and their loved ones and people that matter to them in those kinds of situations. So we definitely want to be mindful of that. We do have two key objectives for today, and one is just to talk about and share with you and get some dialogue going around the role of social workers in advanced care planning, because certainly, again, I certainly am embedded a lot in the research out there, and advanced care planning and social, it really fits well within the scope of social workers. So we're really hoping to explore that a little bit, and Andrew will talk about that. And then to really, move forward with the understanding how to plan in advance. I think that we are definitely blessed in Canada to have some national sort of lens and framework to this, but also to be mindful that we have different laws across the country. So it tends to be a bit different, maybe legal wise, document wise, legal term wise, but really there's a lot of things that across Canada and across the world actually that are quite, sort of that underlying philosophy with advanced care planning. So the three things, you'll see this slide come up several times today, and thanks to Laura for really being the person who was creative with this. So when we go through things today, we're really going to have three sort of perspectives that we're going to lean on and lean into, and that's personal. So really looking at that personal perspective, because we think that's really important to look at, professionally advanced care planning for sure. And then in also the different roles that maybe you're in all the settings that you work in around you being a facilitator or a mentor for advanced care planning. So certainly, again, we're hoping to be able to touch on all three of those things, thinking that they're definitely interlinked and very important. I just have a couple of more things to say, and then I hand it over. So I just mentioned that we are lucky in Canada to have a national framework around advanced care planning. So many of you may know, but for those of you maybe who need a little bit more information around that aspect of the Canadian lens, we do have an advancedcareplanning.ca site, and if you click on there, it's Speak Up Canada, Advanced Care Planning in Canada. Lots of information on there. Each of the provinces and territories, there's an interactive map of Canada where you can click on it and see the place in which you live or where your family lives, and really get a good sense of what's going on in each of the provinces and territories. Lots of resources on there as well, but certainly lots of great information about what's happening locally. We did put a reference on this particular slide, and so there was a chapter written in 2018, so not too long ago, with Dr. Barwick, Dr. Jessica Simon, myself, and Louise Hanby, just to give some history of advanced care planning in Canada. I think we have a really unique history of advanced care planning in Canada. So if you're one of those people like Andrew who really likes to read things, feel free to have a little look around that. In Canada, we have a framework for advanced care planning. We've had it actually for quite some time, but it was recently revised. And so it's been adapted actually in New Zealand as an example, and other places in the world as, how do you do advanced care planning, and what are the things that, what are the wheels that really need to be in place to keep things going? So within this framework, we sort of across Canada got together with community partners. There was a meeting in Ottawa when we could all be together, and it was around, one important aspect is extending the partnership network. Another one is engaging and educating the public and healthcare providers at the same time, as well as others, measuring impact, and building supportive systems. And I think that we've come a long way with this framework. And if you haven't had a chance to look at it, it's broken down even in that framework around what are the things that you could specifically do in this framework, locally within your own organization or within your health authority to really move things along. And in November, through Speak Up and through our national partners, we are having a learning institute where we're going to dive a little bit more into this framework. So there is a conference coming up if you were interested in learning a bit more about that. So I thought I'd also put that plug in today, since I have a nice audience today. But now I'm going to hand it over to Andrew and let him take the lead from here on in. Thanks, Andrew.
Thanks, Carrie. Let me introduce myself. My name is Andrew Saunderson. I'm a social worker here in British Columbia. Also, I cover the north area of our health authority, which has been a privilege. And I'm really excited to share some of the research today. I know it might not sound like the most engaging or appetizing part of today's presentation, but I think it's really important for us to situate ourselves in the literature, in the research, and especially really understand as social workers how prominent our role is and how important our role is in the field of advanced care planning. So you'll notice on your screen there was a really great review of the literature, specifically identifying areas in which social workers engage in advanced care planning, what their perceptions are, what their involvement is. And this review was completed in 2018. And not surprisingly, as evident in our attendance today as well, and those who registered for today, most social workers have a positive attitude towards advanced care planning, particularly those in health and aging areas. But again, as Randy and Carrie highlighted, I think COVID-19 has reminded all of us, whether in private practice, frontline, or wherever we might be working in policy, that really having conversations about how we want to live and about our mortality is equally important for all of us. Now, usually, as is evident in today's presentation, education and training around advanced care planning for social workers is done in continuing education programs. So it's not yet formalized within most bachelor's or master's program, although that's part of the work that we're doing here in British Columbia, is building those partnerships with our schools of social work so we can embed it from the beginning. You'll also notice that over 90% of healthcare social workers have engaged in advanced care planning conversations, but only 30% have actually initiated those advanced care planning conversations. And I think what's always concerning to us about that number, and that you'll see in some of the information that I think Laura and Randy are going to share in a few slides from now, is that people in Canada are already thinking about advanced care planning. They're thinking about how they want to live. They're thinking about their future healthcare decisions, who would express their wishes if they're not able to. And yet oftentimes it's our responsibility as social workers to initiate that conversation and to at least start asking the questions to gather that information. It's also interesting to note that over 64% of social workers reported that their direct responsibility is to discuss advanced care planning. Some of this data is likely not going to be surprising, that based on, I think, the communication skills that we have, the advocacy skills that we have, and the values that we have as social workers, I don't think it's a surprise that the literature found that social workers are the most confident in having advanced care planning conversations compared to other health disciplines. And again, part of our responsibility as educators and as systems leaders here in the Fraser Health Authority in British Columbia is to slightly change some of that so that we're not just defaulting that all advanced care planning is the responsibility of advanced care of social workers. We know that they are the most confident, they're often drawn on, but we also want it to be an interdisciplinary practice and work. Ethical issues, again, you're going to learn today, if you don't know already, that at the heart of advanced care planning is this idea around self-determination. The idea that we want to ensure that the healthcare that we receive as individuals aligns with our values, who we are, and how we want to live, so that we can have that self-determination approach in all that we do, and especially within a large healthcare system that often feels slightly powerless or uncertain. And then the effectiveness of advanced care planning engagement. They find that social workers' involvement in advanced care planning actually increases patients' conversations with other healthcare providers. It actually increases their documentation of advanced care planning, and it also increases their appointment of a substitute decision maker. So really highlighting the value and importance of social workers in this work. Also highlighting the importance that as patients, forgive me, my screen just went black for a second, that the patients report higher agreement scores for the treatment preferences that they receive after engaging in advanced care planning, specifically with social workers. This was another research article that came out in 2017 about social workers and advanced care planning. I think for me, the only challenge that I have with it is that it only targeted palliative social workers. And you're going to learn today that advanced care planning is not an end-of-life work. It's not focused on death and dying. That is a part of advanced care planning, but it is not the heart of it. And so we really want to expand advanced care planning to far more than just palliative social workers, which again, we express our gratitude that you're here with us today, because we know that more of you are not just palliative social workers, if not the majority of you are not. But you'll notice that again, 96% of those palliative social workers have conducted conversations. I think what's an interesting statistic from this research is that documentation. So while 96% of the social workers did have these conversations, only 68% of them documented. And the reason why I bring that up and why it's an issue for me is that I always feel like a plan is only as good as it's followed. And so if it's known and followed. And so while we're having these conversations, that's a gift that we're offering these patients and these families and those who are important to them. However, making sure that we actually document it and that our healthcare providers are aware of them allows us to ensure that we follow those plans and those conversations that have been started. Benefits of advanced care planning education with social workers was also documented in a couple different studies. And what I loved is, and it kind of got me excited about what our outcomes would be after today's presentation. You'll note that self-reported level of preparation to have advanced care planning conversations pre-education was about 36%. So perhaps that statistic might be true for our audience today, is that 36% of you felt pretty prepared and confident in having these conversations. You'll notice that post-education, it went all the way up to 82%. And even 4 months post that education, there was almost a 9-fold increase in the number of initiated advanced care planning conversations by the social workers who had that education. So I'm not sure if we're going to hit those numbers, but I'm hopeful that by the end of today, potentially we'll be able to get 82% of you feeling more prepared to have these conversations. You'll also notice, and this is why we touch on this throughout today's presentation, is that our personal experiences significantly influence our advanced care planning engagement. And that was identified both in the literature, and I think it's probably anecdotal research for most of us, that we realize that when we've had experiences with people who are close to us and having to either express wishes or make decisions for them, or having been in health crises or unexpected situations, that all of a sudden that allows us to engage or have more empathy in our advanced care planning conversations. So we're hopeful today that throughout our presentation, in addition to learning about how you can do advanced care planning with the clients and the patients that you work with, then more importantly, you're going to learn how to do advanced care planning for yourself, which will then enhance your ability to be able to connect and empathetically support your clients in having these conversations.
Awesome. Thanks so much, Andrew. And I think you're going to hear that point made over and over today throughout our presentation. As professionals, as educators, it's really, really important that we do know about advanced care planning, how it fits within our role as social workers and as professionals. But as Andrew made the point, I mean, it's also critical that we know and recognize and appreciate that as mortal beings, it's really important that we also keep advanced care planning in mind for ourselves. And there's no better strategy, no better education than going through advanced care planning exercises ourselves and doing our own advanced care plan in order to prepare ourselves as well as to prepare and support those that we work with to do their advanced care planning. So the slide you're seeing now is, basically a picture of a very stereotypical lifespan, from youth to old age. And typically what we would expect to see is, and what we do see is advanced care planning thought of at the 11th hour. When someone is in palliative care as they're transitioning perhaps to residential care or extended care in the ICU or in the emergency room. The point we really want to drive home today is that advanced care planning is a process that occurs across the lifespan, and it's important to consider at all stages, all the way from young adulthood all the way through our lifespan. it is also something that needs to be revisited as our life changes. Our values, how we want to live our life changes. Whether we view ourselves as a person wanting CPR is certainly going to be different whether we're 20, 40, 60, 80, 90 years old. It's going to change. Very similar to making a will. You don't make a will when you're 25 years old and then feel that you're done. You're going to revisit that will at critical points throughout the course of your life. We just want to play a very short video. It's about 5 minutes long. It's out of Australia. And I think this will really, really ground us and will really help us get a sense of how advanced care planning fits for individuals at various stages of their life. I'm getting a bit of a strange view here, so I'm wondering whether someone can give me a hand just in activating this video.
Is that Randy? It's Carrie. Is that you trying to? Because I can't see anything.
No, I'm seeing the video at my end.
So Roy gets to go on a trip of a lifetime. Where does he want to go? I'd say Bora Bora.
I definitely want to go Bora Bora.
What food could Anita not live without?
Probably curry.
Anything Asian? He couldn't live without a lot of food. And what about you? What food could you not live without? Probably fruit in general.
Probably chocolate. Anita asked me, so what's yeah. So I don't know.
If you can think about a moment where you pushed through a hard time together, can you describe that?
At school, when she was being bullied, we had to see some counselling.
Just talking me through it and helping me get through it. Kind words and lots of hugs.
For me, it was probably the time that we were first trying to have our first child, I guess. We went through IVF and things like that. Becoming parents is something that we all hoped would come naturally, but it didn't to us initially, and we worked through that together.
Roy's hurt in a car accident. He needs a breathing tube for the rest of his life, and he'll never speak again. Would you consent to this?
Well, yeah, I would, yeah.
No, I wouldn't. Definitely not. I don't think I would want to burden anyone with that. So I'd rather not. Yeah.
Anita had 3 months to live. Treatments would give her an extra 2 months, but she would never see outside of a hospital.
All right. I hope that video showed up okay for everyone. It showed up okay at my end, so I'm just going to trust that it worked for everyone else as well. Just wanted to go through a couple of the excuses that we often hear in regards to advanced care planning. People will say such things as, "I'm young and healthy. My family makes decisions together. We haven't had great experiences with the healthcare system," and other similar excuses. So there's always excuses and reasons for not participating in advanced care planning. And as I alluded to in the video, I mean, for many, it may not be a comfortable topic to discuss their own mortality. However, it certainly takes a burden off of our family members to have them well prepared and well equipped to make decisions on our behalf should or when the need arises. So, I mean, imagine struggling to make some of your own decisions or to communicate them. Very often, others will need to make decisions on our behalf. Life is unpredictable. Planning helps give us control over what happens to us through the course of our lives. And in the event that we don't plan, the law decides for us in any case what's going to happen. So the laws are going to be different in every province, but there are provisions under the law whereby someone else will make the decisions. In British Columbia, it's the Office of the Public Guardian and Trustee, and we strongly urge people to participate in advanced care planning in order not to have the Office of the Public Guardian and Trustee, an organization which will never meet the patient or client, and will be making critical life and death healthcare decisions on their behalf with little or no information in regards to what that person's preferences might be. So here is a survey that indicates that 71% of people have thought about their own healthcare and decisions in regards to their own healthcare. I'm just losing things here on my screen. It's difficult. It looks like 48% have spoken with their family. 27% have recorded this. Yet only 10% have discussed their wishes with their healthcare provider. These are things that we really do need to talk about. And as social workers, we're really well positioned to initiate these conversations with our clients and with their families. It helps us connect with them. It helps us to connect them with each other, and it helps to connect all of us with our own mortality.
Okay, so just before we kind of dive into something a little bit, I guess you could say juicier, I just want to go over kind of a cultural concept here around healthcare decision making. And as all of you probably are aware, for the last, for your whole lives, I know with my own grandparents' generation, healthcare decision making has primarily been very paternalistic, right? So doctor knows best. And sorry, I just have to shift my screen here. So doctor knows best. They are the experts. Healthcare provider knows everything. So whatever is being recommended, this is what needs to happen. So obviously there's a little bit of a gap there, right? Like, there's a piece of the puzzle in terms of the person and how they actually want to live that's missing from that type of concept. And so what ended up happening is the pendulum kind of made a shift as kind of the attempt to bring in the individual person into the equation happened. And unfortunately, it swung a little bit too far the other way and ended up being the consumer knows best, and the person could demand anything that they wanted, totally missing the educated piece about healthcare provider having that background knowledge about what's happening with the person's health. So what really the goal is here is that we can shift things not all the way back again, but somewhere in the middle there, so that we have this concept of shared decision making, right? So we're looking at right here in the middle, the healthcare provider being the expert in the medical side of things, whether it's a doctor, nurse practitioner, social worker, whether it's a physiotherapist, whoever, they're the expert in that medical field. And then we've got the person who's the expert in their own life. Here we go. So here we've got more of that definition of the shared decision making. So again, patients and families are the experts in their own values, goals, preferences, how they want to live. And then we've got that expert opinion who is able to kind of look at, okay, this is what is going on for this person with their health. This is the options for treatments that could be offered to this person. And then together they have that conversation about how those pieces fit together and what type of care plan should be made going forward that honors both the needs of the health concern, but also honors how the person wants to live going forward in their life. So here's the part that hopefully will be a little more interesting for you guys. As Carrie was saying earlier, we do have a national organization called Speak Up. And so we're very lucky to have them and guide all of us, regardless of whether we live in a province or a territory all across the nation. And so they have the 5 steps of advanced care planning, which we use frequently within our own work when we're talking with the public or when we're talking with other healthcare providers. And what I really like about this process is you can see on the screen there, we have a circular look at it, right? We've got a process that might seem linear. You got step 1 through 5, think, learn, decide, talk, and record. But it is a process, right? That an ongoing process. And I believe Randy had mentioned earlier that it's ongoing. You don't want to use it like a will where you stick it in the safety deposit box and never look at it again. You want to constantly be revisiting this and go over and see if it still fits for you as you go, as you age and through your life journey. You want to make sure this still fits for you. And what I really like also is that, as all of us know as social workers, there's no start and stop point on a circle. So you can really make this process your own and really personalize this process, because maybe you're someone that works better at talking about things first, and that helps you with your thinking process. So you can start there and you can jump around or spend more time on one section. Maybe you feel like you are the type of person that needs to learn more about what's going on with yourself. And so maybe you sit in that piece of the pie a little bit longer, and then move on to something else. So it's really a personal journey, which I think is fantastic. We can really personalize it regardless of the diversity of our own lives, but also the diversity of the people that we are working with. And what we'll be asking you to do going forward is we'll first start off with asking you to wear your own hat, your own personal hat, your own journey going forward with this. But then there will be a point at the end of each section that Randy and I will be asking you to take that cap off and stick on your cap for when you're speaking with your clients or your patients.
Mm-hmm. Yeah, I mean, I think it's a really important point to make that, it does make sense that social workers are definitely better prepared to have advanced care planning conversations with their clients and families and to really better understand the process if they themselves have been through it. I guess it's really not much different than a counselor or a therapist who themselves have been through counseling or therapy. I think it much better equips them to understand the client's journey through the process. Just as anyone who's executed a will or an estate is certainly going to be much better equipped to coach another through it. And like any other skill, having these conversations can be tricky. And practice. With practice comes familiarity, confidence, and competence. So we really do encourage you throughout this talk today, to really consider your own position within advanced care planning with your own family. Many of us are caregivers for aging parents, and we may have children at home as well. So we may be in a sandwich generation and have many factors to consider. So if we consider our own things, it puts us in a better position to consider those of our clients as well.
Okay, so we get going on step 1, and we're asking you to think. So what are we really asking you to think about as we're going forward? Because I'm sure if you guys are anything like me, I'm a social worker, I've got 101 different browsers open in my brain at any given time. So what are we asking you to think about? So really, we're asking you to reflect on your personal values, your beliefs, your wishes, and how they relate to your health and how that might relate to healthcare down the road. So that's kind of a big ask. So we very much realize that. Values and beliefs, there's something that really drives every decision that we make, and it's a big concept. So there could be a lot of questions that are sitting there with that. So what do we mean by, reflecting on your values, your beliefs, and your wishes? So what we're really asking you to do is really reflect on what gives your life meaning. What brings you purpose and joy throughout your week? What does a good day look like? What brings a smile to your face, or helps you wake up during the day? Thinking about how you really like to spend your time, and not just maybe in the moment, but spending your time from a bigger picture as well. So just these big, it really gets down to those values and beliefs and how we want to live our lives. Right? These are these thoughts that we would need to think about.
Mm-hmm.
So then taking off our... Sorry, go ahead.
No, sorry, Laura. No, I was just going to paraphrase the story from Atul Gawande. So Atul Gawande is a physician and surgeon in Boston, and I'll paraphrase a story that he shared. Dr. Gawande expressed how he felt physicians weren't really well equipped to have advanced care planning conversations with clients, or they weren't very effective at it. And he was working with a palliative client who was very near the end of her life. And in discussing with her her situation, one of the things that she shared was that she had really, really badly wanted to, and so wished and so regretted, not being able to take her grandkids to Disney World. That was something that she had really, really wanted to do. And a week later, this lady would pass away. And Dr. Gawande reflected on this and thought back that at the time of this conversation with this woman, had this been brought up 3 weeks or a month earlier, had he asked her what really brought her joy, purpose, meaning in her life, what might remain on her bucket list, things that she wanted to do with the remaining time that she had left, Disney World might have come about, and it could have actually occurred. So the focus of the care could have shifted, and instead of trying to prolong or add quantity to her life through treatments that would perhaps extend her life for a short period of time, immense quality could have potentially been added to her life by allowing her the opportunity to have this one last trip and these memories for her and for her grandkids and for her family. And, he recognized and I think changed his practice after that time and began to really see the value of having these advanced care planning conversations and questioning his patients and clients that what does bring them joy? What brings them meaning? What brings them purpose? What do they do on a perfect Saturday, right? So, I just wanted to bring that up, Laura. Thank you.
Yeah, thank you, Randy. And so that's a perfect example kind of for our tips and techniques for you guys. If you are working with your diverse clientele that you have, I think Randy's story actually covers a lot of the points that we bring up there, about the joy list, just as Randy said, describing a perfect Saturday. And I think one thing to really remember as well, because sometimes we hear that advanced care planning and these ideas of these conversations can be very overwhelming. But really, we're probably all doing this type of work already without even realizing it, right? Especially as social workers, where we have our psychosocial assessments, and we're often trying to learn about the person that we're working with through whatever type of care or platform that we are working with this person. So really, the key is around rapport building, right? So it's not necessary for us to build rapport and then do advanced care planning. Part of building rapport is getting to know the person, which is essentially the root of advanced care planning, especially when we're talking about, we're trying to find out what brings the person joy, what brings them meaning, what are their values and beliefs. So we have that quote at the top of the page there: building rapport isn't necessary to start advanced care planning. Advanced care planning builds rapport. So we're likely already doing that. Is there anything else you wanted to add, Randy, before I moved on?
No, I don't think so.
Okay, great. So then we'll move on to step 2, and step 2 is learn. So really the question comes up: what do values, beliefs, priorities, wishes, what do all those things have to do with our health? And as I said before, values and beliefs really drive the actions that we take, right from when do we wake up in the morning, who are our peers, what type of hobbies do we like to partake in. This is all to do with our values and beliefs. And so that link between our values and beliefs and creating behaviors and our healthcare and what we want from our healthcare is this learn section. It's a bit of a bridge, so we can really review certain concepts within and learning of these certain concepts so that we can bridge between our values and the actions that end up being taken later on down the road. So one of the really big questions that can come up is, how do I prefer, what are my preferences? How do I prefer to be communicated with? So when we're looking at ourselves, how much do I like to know about my health? So I know for myself, I like knowing as much as possible, and then I can take that home and really process that information. But not everyone is like that. And I know when I'm working with a patient or a client, they might have a different preference than my own as well. And how do I like to make healthcare decisions? So am I someone who likes to go home and come up with that decision on my own, or do I have a support network or a family that I like to discuss and make decisions with, or is there some other mode of making those decisions? So that's one thing to really reflect on for yourself when going forward. And another question: what do I need to know about my health? So this is where we'd be learning more about our current health conditions. So that could be maybe I've got diabetes, or I've got a heart condition, or it could be a mental wellness issue, or it could be a sprained ankle and you're going to physiotherapy. So when we talk about health in this case, it can be broad, not necessarily just life-sustaining health issues there. So some of the questions being, what does my health condition mean for me in my life? What is my life going to look like in another 1 to 5 years as this condition progresses? What are the possible treatments? Where are these treatments going to take me? what are the benefits and maybe some of the detriments to these treatments, and what might lead to the end of my life. So these can be very important questions to bring up with a doctor or nurse practitioner, particularly if you have more of a chronic illness framework. To tie on to that as well, it's good to know that, again, going back to that shared decision-making model, a person's not going to receive everything that they demand of a situation. You can't demand for specific care. Yes, you come to the table with some of your beliefs, your values, and things that you want to wish for your life, but sometimes those some values might need to be traded off, because again, it's what is being offered on the table from that health professional perspective. So they know the trajectory, they might know what might be ahead in terms of the health journey, and so they would be able to offer certain types of treatments and then figure out if that's going to match with what your individual values and how you want to live. But there's no way of actually demanding certain treatments. So it's really good to find out, what is being offered to me for my health condition, what are my options, and then being able to ask other questions beyond that. And the next big question to kind of review and look at, and again, this is going to be different across all the provinces and territories across Canada here, but what do I really need to know about the law, right? So what legal documents might I need for my situation? Do these documents, can some of them can I do by myself, or do I need to go to someone for legal guidance to have these filled out? And what happens if I can't speak for myself? If I'm unconscious, or if I've developed some sort of brain issue, like an acquired brain injury or dementia, that causes me not to be able to speak for myself or make decisions for myself. Who's going to speak for me when I'm not able to? So here we've got legal documents specifically to British Columbia. We've got our enduring power of attorney, which is to do with finances, our representation agreement, which is more around healthcare and personal care, and our advance directive, which is more of direct wishes. Again, as I said, every province and territory is going to be different. They've got different language, titles. The legislation behind them is different, but ultimately the intent is going to be similar across the entire country. Generally, the public often gets confused by the different language, at least what we're finding. And one thing that's great about Canada is we're very big and we can move back and forth. I know for myself, I am born and raised BC, but I've also lived and worked in Ontario and Alberta. So same with the general public, right? We're all mobile. So that can be quite confusing for people. So it's good for us as individuals to learn, what are the specific legal documents for where I live. One that often gets misinterpreted is the term the living will, which is not a thing in Canada, unfortunately. That's something that's very much in the States. Other examples that are out there, we've got the personal directive, which is in regards to healthcare decision-making and personal care in Alberta. And then my understanding in Ontario is it is the power of attorney for personal care is the term. And every province and territory will have something that's a little bit different. So just the tips and techniques for the learning section. It's okay to just ask our patients or our clients those questions that were on our previous slides there, particularly around preferences, right? If we're working with someone who has a different culture than our own, that really learning about how that culture, how that diversity of that other person impacts how they want to be communicated with or how they want to receive information is really important. Being aware of your own bias and agenda is really key. Because maybe the person, as us, all of us social workers know, we want to meet the person where they're at. So they may not be ready for this part of their advanced care planning journey. So really it's about letting the client lead the conversation and even just checking in with them as you're going through these questions so that they feel supported to back out of the conversation at any point in time if they feel like they've reached their limit. So we're there as a guide, walking with them rather than fully leading them, and they choose the direction that we want to go. Sharing a story about what's happened to someone else, making it relatable. Randy's our go-to guy for all of the great stories that we have when we provide education and things to public and to healthcare providers. So he's a great resource and is able to really bring value to that within the practice. And what do you already know about the client? Right? So maybe you already have a rapport, a relationship with this person, and you could use that as a baseline or a platform to start these conversations coming up. Or is there something about their social work network to be able to start with these questions and really making them think and learn going forward?
Mm-hmm. Yeah, thanks so much, Laura. And, I just wanted to share one really quick story. In British Columbia, we have something called representation agreements. So this is basically when an individual chooses another individual to speak on their behalf to make healthcare decisions should they not be able to make them on their own. And in BC, we have a handy little guide. It's called the My Voice booklet. It's actually not a little book, but it's quite thick and a little bit complicated, not really user-friendly. But there is forms in there for a Representation 9 agreement. And these are legal forms. They can be completed for free and retained and used to name a representative. However, in BC, lawyers can also do Rep 9 agreements. And there are times as a social worker when I would recommend an individual consider a Rep 9 agreement and just doing one for free out of the My Voice booklet. There's other times I would strongly recommend clients go to a lawyer and have the Rep 9 agreement prepared. Usually I would recommend this if litigation is a very real possibility. If there's a family in conflict, and just from my own personal experience, the times when I would recommend a lawyer, there's usually a big pile of money at the end of the rainbow, and these are times where families are likely to get into a great deal of conflict. And sometimes, then in BC, we would suggest perhaps having the Rep 9 agreement done at a lawyer isn't a bad plan, just to avoid further problems down the road. So I am just endeavoring to advance this slide here now, Laura, and for some reason this is not cooperating.
There might be a bit of a delay. Hang on, I can move it for you, Randy. Don't worry.
Yeah, I don't know why. Maybe I've just changed my view on here or something. I'm not sure exactly what it is. Just 1 second to regroup. I apologize. Okay, so step 3 is decide. And what are we deciding? What we're deciding in this situation is, and again, I want to advance the slide and it's not showing up for me. Or maybe I'll get you to advance these for me. I don't know why my button has disappeared here. So what are we deciding? I mean, we're deciding who is going to speak for us in the event we're unable to speak for ourselves. I guess something that I would ask you to consider is, what qualities would you look for in this individual? What sort of traits or characteristics? I mean, if you like, maybe you can share in the chat box some of the qualities that you feel would be important of a representative or a substitute decision maker. So if you weren't able to make your own decisions and someone was going to make these decisions for you, what qualities and characteristics would this individual have? So, as I said, I'll invite you to just put them in the chat box, and if one of my team members can sort of observe that and give us some of those. So, I mean, some of the things that have typically come out in the sessions that we do in person are, someone who knows me well, someone who's available, someone who's able to suspend their own ideas of what might be good for us. So, someone who's respectful of our wishes, even if they don't agree with them necessarily. Someone who's good in conflict, mediator. Someone who's able to remain calm, maybe someone who's a good advocate, someone who's a good communicator. Now, is there anything coming up in the chat box? Has anyone contributed other qualities or characteristics?
Yeah, Randy. So we've got someone, Justina says, a strong, assertive communication style. Courtney says confidence. Mm-hmm. Christine says someone I trust to speak for me.
Okay. Yeah. I think those are all really, really good qualities and characteristics of people that you would want to speak on your behalf. Again, Laura, can you advance for me, please? Excellent.
There's lots of other ones that are coming in that are fantastic.
Do you want to read out some more?
Sure, if you'd like. Sorry, I know there's a bit of a delay here. Sorry. Someone who has previously supported my decisions. Someone who's willing to ask questions even if they think they know the information. Mm-hmm. So asking questions rather than just agreeing with everything. Someone who knows me and my values. Emotionally well enough to hold the role. Calm under pressure. All really good answers.
Right. Okay. No, that's great. Thank you. And those are all answers that we often get when we do our in-person sessions prior to COVID hitting. So these are all things that we often hear. So this next slide here is just one that illustrates the various different laws that are in place across Canada for substitute decision making. Across Canada, the legislation does allow for individuals to name another individual to make decisions for them, should they not be able to make decisions themselves. But there are also laws in place that govern the order under which the healthcare system approach others in the event that you haven't chosen a representative for yourself. So this can become very interesting in acute care, extended care, etc., in emergency and ICU, when a critical decision does need to be made and an individual hasn't chosen a representative. Families certainly aren't all uniform and standard, and they, as we all know, they don't always get along. So things can get pretty mucky at a time that's already really, really difficult. So, we just strongly urge people to know the legislation in the province in which they're practicing, or in which they reside, because again, all of these issues impact us as individual mortal beings as well as professional social workers. So it's important to know this legislation and know who your representative would be, whether you're naming a person specifically or whether it's under temporary substitute decision maker laws. So next slide, please. Excellent. Thank you so much. So substitute decision makers have to act in accordance with the wishes of the person that they're representing. They should know your condition and its likely course. They should know the different medical options and be willing to listen to them, hear about them, including the benefits, risks, alternative treatments. They should know your current wishes and specific instructions that you may have left. And they should be familiar with your values, preferences, and expressed wishes and desires. I've asked that this slide be amended a little bit. It used to say substitute decision maker, and I like it better the way it is now, with the maker crossed out and communicator, because as individuals assigning authority to another individual, I think part of that assignment is ensuring that our substitute decision maker has been communicated with and is fully aware of what our wishes would be. Now, that isn't necessarily speaking to every single medical intervention, but it is speaking to what brings us quality of life, what's important to us, what are critical activities or functions that we wouldn't want to live without. So this could be something like eating. It could be mobilizing. It could be toileting. Someone may be comfortable with a temporary tube feed if there's a possibility that they would be able to take food orally again in the future. So all of these things are important to discuss with a person that could be your substitute decision maker, or in this case, substitute decision communicator, as well as with your family and others, because the person communicating your wishes will need the support of your other family members and those close to you. So it's important to communicate with everyone. And of course, I'd be neglecting it if I didn't say to also communicate your wishes with your physician, nurse practitioner, and your healthcare team. This becomes really important in the event that you have chronic illness, disease, and you're in regular contact with the healthcare system. Then absolutely you need to have these conversations. So next slide, please. Excellent, thank you. So just a few tips and techniques. So asking your client who they reach out to with good or bad news. This can often be a clue as to who might make a good substitute decision maker. I would never suggest to an individual, well, it really sounds like your brother Brad would be a good substitute decision maker for you. But I would perhaps make my client aware that the temporary substitute decision maker hierarchy in British Columbia might name an individual's spouse, or does name an individual spouse, as the highest ranking substitute decision maker. So if they're not wanting that spouse to be their substitute decision maker, they do need to identify someone else. So again, I've mentioned this several times before. We have going through the substitute decision maker list for yourself before trying it with your client. See how it fits for you, so that you're better prepared to have these conversations with clients. And going through the list with clients and asking them, are they okay with the order of the list? In BC, not everyone does need a representation agreement. If you're okay with the hierarchy, you have a somewhat functional family, and your spouse, your kids, and the other people close to you know your wishes and are available and ready to speak on your behalf, then you're probably okay in BC. Otherwise, you probably want to look towards a rep agreement. Laura, story time. I think it's your turn here.
Yeah, thank you.
Are you ready with a story for it?
Yes, I am. So I just wanted to bring kind of, as all of us probably are aware, we do work with diverse people. And when it comes to decision making, when we're working with people, sometimes culture does kind of make that a little bit sticky, regardless of what the laws that we have are. And so social workers are in a good position, I believe, to kind of bridge that and be able to provide education, as well as supporting patients as they are going through the healthcare system, or our clients who might be looking into receiving healthcare, if we're more in a community position. The experience that I wanted to share, because I used to work in a hospital alongside an Indigenous liaison, and there's this one scenario where a person came into hospital and they had their community spokesperson who came to support them as they were going to emergency room and then whatever healthcare that they needed. Now, this particular individual was the community spokesperson, and they were given that role by the community because they had strong advocating skills and they were quite outspoken and asked a lot of questions, and was really there almost as an overpowering or seemingly overpowering presence. So the general healthcare practitioners got their backs up and they were very concerned about possibly an abuse case right here, because they didn't realize that this person that was taking the patient through the system, that was their role and that was their community role. It was something they held with honor and they took very seriously. So being able to come into that as a social worker who has some appreciation or maybe a little bit of background knowledge about that type of diversity or at that type of information, being able to be the link between that particular Indigenous family and the healthcare system, being able to educate both sides and be able to show that, no, this is not an abuse case. This is actually the way that this community does things. And so they are actually taking on a very important role, but also educating the patient and their community that this is how the healthcare providers, the laws that they are following within Canada, that it falls onto all of the people who live in Canada, so that there isn't any of that misunderstanding there, still being respectful and mindful, in this case with the Indigenous family, of that fear and historical racism within the system. So luckily, that particular case didn't actually end up going to public guardian trustee. There was a way of bridging that communication there, but just kind of an example of understanding that there is diversity when people come into the healthcare system, and we can play a very vital role in making sure that there's that bridge with the understanding of the laws within our province or territory, mm-hmm. and how substitute decision makers are present in a particular case.
Yeah, Laura, that's such an excellent illustration about how several different cultural groups, various communities, and even religious groups may not line up real nicely or real neatly with the legislation in our areas. So I won't go completely off script here and put Carrie on the spot, but if we do have time towards the end, I wonder, Carrie, whether you might want to share the monastery story at the end, because I think that would really, really illustrate how a very unique community is still faced with the laws of the land, and they need to take specific steps in order to ensure that the right individuals for them are making the decisions on their behalf. So in our provinces, the laws are such that we generally can choose an individual or spokesperson or people to make decisions on our behalf, but we do need to be aware of the legislation, because otherwise the law will decide for us, and it doesn't always go in the direction that we might think or we might wish. So that's something to consider. So the next section, step 4, is talk. And I don't have to tell social workers, talking is critically important. I'll get you to advance the slide, please, Laura. Thank you. I don't know where my advance button went. It just disappeared, my next button, but that's okay. We'll just work through it. So talking is critically important, and we aren't mind readers, as the video that I presented earlier from Australia illustrated. Our families may know our favorite foods, and they may know many other things about us. They may know whether we would like such things as life support, intubation, things like this. But as we saw in the video, they may not. We're not mind readers. our family do know us well and may be able to make good decisions on our behalf. But my goodness, what a burden to cast upon them, to give them the authority to make decisions on our behalf, but then not to arm them with the information needed to make good decisions. One example, in British Columbia, we have something called power of attorney. So power of attorney is simply for financial and legal affairs in British Columbia. So imagine, if you would, that I gave power of attorney to Laura to manage my financial legal affairs, and let's say my house is up for sale and I take off for a trip to Europe. Well, all is well and good, and I did well to assign this authority to Laura. Well, an offer comes in on my house. Now, what's Laura to do? Well, I've given her the authority, but I haven't armed her with the information. She doesn't know the closing dates that I want. She doesn't know what is critical for me to include in the sale of my home. She doesn't know the price, the lowest price that I would accept for my house. So I've given her the authority, but I haven't given her information and instructions. So this is where it's just critically important that we talk to the people that are involved in these decisions, and certainly to our representative and to our healthcare provider, about what it is that we would want, and more so what it is that we value in life. So where we want our healthcare treatments to take us, as opposed to listing every conceivable healthcare option available. Next slide, please. Excellent. So just want to ask, who are the people that you talk to in your world, and how do you talk to these people in regards to your wishes? So these are just a couple of the things that we would suggest that you could conceivably use. Asking, I want you to be prepared if you have to make decisions on my behalf. I want to talk with you about what's important to me. I would like you to go to medical appointments with me. And, I think it's really important that my family understand what it is that is important to me. So in my own life journey with my own mother, this is something that happened with her and I. And as she got older, we began to go down this path, and I began to go to medical appointments with her. And we began to talk more about what was important to her, and where she hoped, her healthcare treatments would ultimately take her. So as a adult son, and as a person who was her substitute decision maker in the end, I really did feel well prepared to make decisions for her. And what in the ICU, when the physician was having what he told me was going to be a very difficult conversation, it was actually quite an easy conversation, in that I knew exactly what my mother wanted. And I was able to share with confidence with the physician and with the medical team present what I knew my mom wanted, and I knew and was 100% confident that I was making decisions that were consistent with her goals and values. So I would urge you guys to do the same, and to also support your clients to be well prepared with their own advanced care plans.
Yeah, so just if we're again taking our personal cap off and we're putting our professional cap on, how can we support some of our clients and our patients with the conversation piece? And I guess part of it is a bit cultural too. So cultural, even for Western culture, we are very death aversive, right? When we're thinking advanced care planning, we're always thinking about, this must be mean that we're talking about death. And so one of the kind of tips and techniques that we have is about normalizing advanced care planning conversations. I can disclose within my own family system, my mom and I are very much, blah, blah, blah. We're great with talking about advanced care planning and some of these conversations. My mom also used to work in healthcare, whereas my dad, he's got an engineer brain. It's very structured, and he's like, nope, this is talking about death. I don't want to talk about it. I don't want to hear it. So we're still working on them. And so we're still working on normalizing those advanced care planning conversations in that family structure. And we can do that with our clients as well and our patients, with having those conversations wherever we work, even sharing that, this is something that you've had conversations with other people. You're not targeting that particular person. Using a current event to broach the subject. So I know the example Andrew likes to use is about Alex Trebek. He had cancer, and so being able to approach the conversation, being like, I hear that Alex Trebek has cancer, and I apologize, I'm not up to date on how he's doing or anything, but being able to say, just thinking about that, if you were in that situation, what would you want for yourself? Or if you're coming from your own perspective, if I had cancer and this is what I was going through, this is what I would want for myself. Something like that. Again, current event, using the example of COVID-19, having that conversation. Lots of people are getting sick, and some people are going to ICU, some people aren't. But if I were to go into ICU, this is what I would want. This is how I would like my life to, I would like my life to look like, regardless of whether I end up contracting COVID-19. Making a to-do list of items with the client, considering their literacy, but working with them, and maybe there's certain points that they want to make when they're having that conversation. So you can help them write out a list of different steps or different ideas that they want to express when they're having these conversations with people. And then encouraging participation of those who matter to the client in with having those conversations with them, with the healthcare providers. So being able to encourage, maybe there's a friend that a person has, maybe they don't have any family, but they've got a close friend, and saying, it's okay for you to have that person there when you go talk to your doctor about this. So encouraging little things like that. Offering to support or facilitate an advanced care planning conversation. As social workers, we have that skill for facilitation, and so that's a great opportunity for us to open up those doors to have conversations between a person and those that matter to them. And really one big thing I find often opens the doors for these conversations is focusing advanced care planning on talking about, this is about life. This isn't about death. This is how we want to know this information so that we know how you want to live, right? It's not about preparing for your death. It's preparing for life. Because even if someone has a chronic illness, most often they live for 5, 10, 15 years with this chronic illness. We all wish that if we ended up getting sick and our last trajectory was, a quick downhill. But that's not very common. The majority of us will have a chronic illness that will last a long time. So that's a lot of life to live. So how do we want to live that? And keeping that in the conversation with your patients or clients can be very helpful. So the last step that we'll be going through is record. And what do we mean by record? So oftentimes we think about writing things down or typing it out on the computer and printing it off for a document. Really, we like to keep this open-ended. If you want to record things through a picture collage, if you want to do a voice recording, or if you want to do a video recording, and anything like that would definitely work. I know Randy likes to joke that you could always do an interpretive dance, but that's not the best way of recording, I think. So any way that you'd like that you can have on record for afterwards it's up to you. That's a great way to leave a lasting message for how you want to live going forward. What are your wishes? So now, what are some of the things that you should record? Well, what are your goals with your life? What are some of those strengths and priorities and how you want to live? Do you have any fears or worries when it comes to health? Like one that I often heard with direct practice work is worrying about pain or having that fear of intense pain at any point in time in their disease journey. So being able to blatantly say that and have that recorded, I'm worried about this, it can be very, very helpful, even just for the communication between the healthcare provider and the patient. They might be able to say, well, actually, here's some treatments that can alleviate pain, for example. How much am I willing to go through for more time? That is a big statement, especially if you're talking with someone about whether they want quality of life versus quantity of life. That's going to look different depending on the person there. And who would be the person's choice? What would be your choice for a person to speak for me? So again, this ties back to looking at the talk, the learn, the decide, right? Who do you want to have speaking for you, and does that align with the legislation there? And again, I can't imagine living without. That also can be a very powerful question to have recorded and left for people so that they know, this is really meaningful for this person, right? So for me, I can't imagine living without chocolate. So if I can't speak for myself and I'm going into surgery, I hope that my spokesperson can say, is this surgery going to allow her to continue to eat chocolate? And if it does, great, go ahead. So just as a brief little example there.
Excellent. Thanks, Laura. Yeah, I just wanted to touch on some paperwork quickly here. So paperwork is always a part of what we do, and in BC and where you're practicing, I'm sure it's no different. Some of the things that we work with here in BC, as I mentioned earlier, is the My Voice workbook, as well as the My Voice guide. We also have the temporary substitute decision maker list, which you see up on the screen now. Also, we have this fancy little green sleeve. In British Columbia, they're quite popular. It's a little magnetized, plasticized envelope where individuals are encouraged to place any advanced care planning documents they might have. So they might put in a substitute decision maker list. They may put in a representation agreement, things like this. Oftentimes people will put in prescriptions, advanced directives, things like that if they have them, and they stick them on their fridge. Emergency responders are trained in BC to look for these documents and to bring them with individuals in the event that they're transferred to a location of care, typically to a hospital. In a perfect world, emergency responders would check the green sleeve even before administering care to an individual. There could be a provincial no CPR record in the green sleeve, which would instruct the emergency responders not to perform CPR on the individual, thereby, despite the individual being, potentially unconscious on the floor, it would still allow their voice to be heard and to ensure that CPR wasn't performed on them. So not a bad idea. There's other regions that are adopting the My Voice booklet. One of the challenges that we get is, that's all well and good as long as I have my medical incident at home by my fridge, which isn't always possible. It doesn't always occur that way. I have met individuals who are really keen on the green sleeve, so they ask for a couple of them. I've had several clients in the specialized seniors clinic who actually had copies of their advance directive, representation agreements, and whatnot. One copy traveled, or one copy lived on their fridge in a green sleeve, and the other one lived in their purse. And they would actually carry their green sleeve around with them in the event something occurred out in the community, and they are transferred to acute care. The healthcare system as well will maintain some form of advanced care planning record, and we're certainly doing that within Fraser Health. These are some of the medical orders and forms that we see in hospital as well as in community. So this is the provincial no CPR form, a goals of care designation form. There's another form we use here in BC called MOST, or medical orders for scope of treatment. So this is a form that is completed when an individual presents in hospital. Each and every time it's completed, and it basically gives a designation as to degrees of intervention. So I don't know exactly what forms and protocols are used in your areas, but it would be a good idea for you to know, and to ensure that both your own and your patients, clients, and families are up to speed on just what happens for them, both in the community and within the healthcare system. So a few tips and techniques. I'm also thrilled that my previous and next buttons are back now, mysteriously. So now I can advance these by myself. So this is fabulous news. Tips and techniques, assisting clients with documenting their wishes, preferences. So the national Speak Up resources can be located at the website indicated there. We have an ever-growing list of resources on our own Fraser Health site, so we welcome you to check that out. And as well, as I mentioned earlier, I think it's a good idea to definitely start a substitute decision maker list after taking a look at your own legislation in your own region. So what would happen if you weren't to name a representative or a substitute decision maker on your own? What would happen? What would the law do in your region? It's certainly a good idea to find out exactly what would happen in your area. So I think I'm passing to Andrew, am I not? Andrew, I think you're muted. Oh, are you there, Andrew?
Okay, well, for some reason we can't hear Andrew. But we wanted to kind of close up with some, we just wanted to close up with some final thoughts here. And if Andrew's able to speak and add to it, that's great. If not, that's okay too. One of the things we wanted to share, again, Andrew had, or I guess it was Randy who had mentioned a tool. Go on, Dee. Oh, I hear Andrew. Do you want to go ahead?
It's working now. I love 2020 has taught me so much about not only technology, but also how to be patient with it. So thanks, guys, for your patience. Sorry about that, Laura. Laura, I don't want to cut you off. You were talking about a tool. Do you want to finish, or do you want me to take over?
Go ahead. I had another closing thought. I'll go after you.
Okay. So this is the Book of Books, everyone. I get zero commission from encouraging people to read Atul Gawande's book, The Immortal. However, I have personally read it 3 times, as I think it does a phenomenal job of both from a social justice lens of criticizing our aging system. And by aging system, I mean for those who are aging and are considered elders or seniors and are assisted living in long-term care situation, which I think has been beautifully exposed in a positive way, and hopefully for changes way in the current situation. And then he also criticizes our healthcare system, that too often we're just focused on helping people live longer and not asking the right questions to know how they want to live longer and what kind of living longer. And I think in closing, not only do I want to encourage you to look for this book, to read it, and to use it as a resource both in your personal advanced care planning and also in your professional advanced care planning conversations. But my closing thought that I really wanted to leave today was, when you think about those 5 steps that Laura and Randy did such a great job of reviewing, personally, I think that the 2 most important ones, and people can totally fight me on this, I'm happy to arm wrestle Laura and Randy later about this, but my 2 personal favorite ones are talk talk and think. Because I personally feel like if I haven't actually thought about, identified, and reflected on what my values are, like what brings me joy, what does a good day look like for me, and what's important to me, and then if I haven't told anyone, like those are the 2 most important things. Even if I never document them actually, or I never actually make a decision on who I want to make those decisions for me, if I've had the conversations, those people, when they're put in that position, even according to the law where I live, will have already known what's important to me and how I do want to live. So I just want to highlight that I personally feel like those 2 steps about thinking, what is it that brings me joy? Make that joy list, a list of the things that bring you joy, and then make sure that people around you have a copy of it and know what's important to you. That's my closing thought. How about I'm going to pass the mic over to Randy for 30 seconds, then Laura, and then Carrie, if she has any closing thoughts too.
Thanks, Andrew. So I guess my closing thought is this, and my team has heard me say this before. I mean, I guess I liken advanced care planning in some ways to depression. And I guess I think back 25 or 30 years when no one talked about depression, people, suffered in silence. But as soon as someone started talking about depression, their experience with depression, it automatically gave other people permission to also talk about their depression. And depression has come out of the shadows, and people are now talking about it far more openly and getting far more help and assistance and support. I think advanced care planning is similar. I think it can be a challenging topic to discuss, but I think it is something that's critical for us to discuss. And I think the more we have these conversations with others, the more conversations that we're going to have. So what we're attempting to do is push for more, earlier, and better conversations about advanced care planning at all ages and stages of life, all the way from 18, 19 years old, all the way up until the very end of life. So don't be afraid to talk about your own mortality and your own wishes, and really just living life to the fullest and living your bucket list.
Thanks, Randy. Laura, how about you?
Yeah, thanks, Randy. So my closing thought is, and something that I'm still trying to learn and grow into, is the diversity of people that we work with in terms of advanced care planning. Really being able to mold advanced care planning into whatever is, mold advanced care planning to whatever type of diverse situation that we're working with. So understanding that we come from a very individualistic culture, and we've got there are a lot of people who still kind of they conform to that. And a lot of times when I hear advanced care planning, I think about how this sits in more of an individualistic culture. But there are a lot of people who live in Canada that come from more of a communal culture as well. So keeping in mind the diversity, whether they come from individualistic, communal, whether there's different types of spokespeople, there's the historical context to different peoples in terms, not just culture, but ethnicity as well. So keeping all of those pieces in mind and being able to take advanced care planning and really mold it to support that diversity of people, and being very inclusive within our conversations of advanced care planning. So as I said, that's something that I'm working on, and I'm hoping that I can help advocate for going forward. So that's my closing thought.
Thanks, Laura. Carrie, did you want to add a closing thought before we move on?
Sure, thank you. I've had some technical difficulties, so I'm hoping that that was just me and no one else. But I just want to thank all of you for presenting. I know that these things are challenging with technology, and I think that this is a really good start for social workers across this country to come together and really talk about why it is it's important for us and for our profession, and to really move advanced care planning forward, and to be part of the interdisciplinary team that supports this out there, whether or not that's healthcare or not, but to really sort of own it a little bit. I think what I heard Randy say many times and Laura say many times, and I think Andrew probably touched on it, was, this is our skill set. This is what we're good at. And I think we should celebrate that and really try to move this forward within Canada. Thanks.
I love that, Carrie. Thank you. So I think whether you knew it or not, we're going to give you a little bit of homework before you leave today. And that's because we're really excited about this kind of two-part series that we're doing with the CASW. And so really what we want you to do between now and October 27th, when we're going to do part 2 of this webinar, is we want you to take a moment and to reflect on some of these questions and do a little bit of practice so that you can get your own individual feedback and experience, and also that we could discuss it even in our next session. So we want you to reflect on, how does what you learned today, especially those 5 steps, how do you see this impacting the clients that you work with? Especially because we know there's a diversity of individuals on today's call in terms of the areas of practice that you're working in. We'd love to know, and for you to start reflecting on, what do you do with these 5 steps to be able to influence and to support your clients? And then also we want you to think about the personal. We want you to think about, how does this fit with you and your family and those who are important to you? What does this mean? Some of you might be starting conversations. Some of you might be thinking of other people that you might want to invite to attend advanced care planning workshops and so forth. And then we want you to give it a try. So between now and October 27th, we've got a few weeks. We want you to try to have a conversation. And that conversation might be a personal one. It might be with someone who's in your personal life. It might be with some clients. And again, those conversations don't have to be all 5 steps. I think Laura and Randy did a great job of highlighting that the intention is not to have a conversation. The intention is to have many conversations. And so even just exploring with people, who's important in their lives? Who are the important people in their lives, and maybe who are the people who are not very important to them, or what are the things that bring people meaning and joy? Do we know why we're supporting them to improve or to heal on their journey, wherever they might be? And then we want to have a conversation about, what are some of the barriers and the challenges that you're experiencing in those conversations in our next workshop. So the next workshop is really going to be about, where do we go from here? So what? What do we do with this information? What plans do we make for ourselves? What plans do we make for our practice? And for our larger organizations and professional associations that we're a part of, how do we implement advanced care planning more into the work that we do? We do have a list of a couple of resources here. We've got our own Fraser Health Advanced Care Planning website that is filled with some fantastic resources, brochures, videos, and so forth, which is fraserhealth.ca/ACP. As we mentioned, our national organization, Speak Up, has a fantastic website that really addresses the needs across the country based on the legislations that vary. People's Law School is an excellent resource in terms of a lay understanding or a lay sharing of the law, especially related to advanced care planning. And then, of course, we've got the First Nations Health Authority, who have created some fantastic advanced care planning resources, specifically a workbook that's been tested and been adapted to be able to meet the individual and diverse needs of our Indigenous people. And finally, we'd like to open it up for any questions. And you're welcome to ask those questions in the chat. You're welcome to ask them in any way, but we'd be happy to spend the next 13 minutes answering any questions that might exist.
So Andrew, I just noticed in the chat box that any one of us could answer. But Christina asks, what would happen if I completed my EPOA and rep agreement, went to another province for a visit, and had a medical event? Would my rep agreement be followed?
We have never been asked that question. I'm just joking. It's so common because especially I think we live in a country where we're very privileged to be able to travel often between provinces and across the country. And I'll let my colleagues correct me on any misinformation I give, but the typical answer that we give to that is that um, what might be considered a legal document that I complete, I'll speak to British Columbia. If I were to complete my legal documents, like my power of attorney, and even my representation agreements here in British Columbia, they are legally accepted as legal documents here in British Columbia. If I were to be in Alberta, they wouldn't necessarily be legal documents as much as they would be considered what we call express wishes. And so everything that I have included in that, in those documents would be looked at, observed, and by law done everything in their power to follow. Now, would they necessarily stand up in a court of law as legal documents? Not necessarily, because they were created out of province or out of territory. But 100%, when people come and visit here in British Columbia or even move here and they haven't updated their legal documents, we look at those legal documents because they were very clear express wishes that they had documented in their previous territory or province that we need to honor within the care that we're providing.
Yeah, and just to add to what Andrew said there, it does depend on which province you come from, because the legislation, as we said, is different in every province. So how the legal documents translate between different provinces and territories is going to be a little bit different. So Andrew explained kind of the process. If someone from outside of BC came to BC, my experience working in Alberta was that there was a little blurb within the personal directive legislation stating if the legal document met ABC criteria, then it would be an equivalent, and so therefore would be held up. But not every province or territory has that same writing right into the legislation, so you really need to be able to take the full legislation and go through it and see, what happens if a legal document for another province or territory comes into this province or territory. What happens with that information? Is it going to be an equivalent, or is it going to be, as Andrew said, a document that is valued as expressed wishes?
And I think just to add to that, Laura, just on the same context again, because we live in a country where often we're moving either within country or out of country, I think it's important to advise that when you're choosing or identifying your substitute decision makers, they don't necessarily have to be local and they have the ability to come to the hospital or to your medical appointments. That might be ideal for some of your needs, and some people might prefer that. But again, there's this beautiful thing called the telephone that was invented a few years ago that allows us to be able to definitely access people more than we were able to before, and that very much takes down that barrier of them having to live locally, because sometimes when we think of those qualities that people so freely gave about who they would want to make those decisions, sometimes we think of really close friends or family members who don't necessarily live nearby. Cheryl's asking a question around whether there's any discussion on creating a nationally accepted document. Again, Cheryl, our organization Speak Up at the national level has done a really great job of bringing together all of our province and territorial advanced care planning partners together. And we try to create national frameworks and national resources that can be applicable. The challenge of creating nationally accepted documentation is just because every single province and territory has different laws. While we have this kind of national Medicare program in Canada, because it's adopted and done on a provincial and individual territorial level, all the legislation is too different for us to make a national documentation that would be able to meet all the different changes. Is that what your feelings are too, Carrie? Oh, it looks like Carrie's offline. She's having challenges again. Laura, is that your understanding as well? Or Randy?
That's my understanding, yeah. And I mean, as I kind of mentioned before, the intent of all the documents is pretty much the same. So there are lots of similarities, but unfortunately, as Andrew said, because all the legislation is different, even though similar, there isn't any direct link that would make it simple to just transfer the documents between each.
But it's
area.
a great question, Cheryl. That would be the dream. Unfortunately, just the way in which our national healthcare system is set up, it's not possible. So at the very least, we always hope and try to make sure that provincially or territorially documentation is all the same, to at least make it easier when we're traveling throughout our provinces and territories. Any other questions before Alexandra cuts us off? And thank you to CASW for hosting this event, and thank you for those of you who have joined us today. It's been a real pleasure and gift, and to be honest, as much as I enjoyed today, I'm really looking forward to the next one, because we hope to make it really, really engaging and have some really rich discussions about how this applies to you personally, professionally, in our professional associations, and so what? What do we do with this information, and where do we go from here?
Well, thank you so much. Can you hear me now?
We can. Thanks, Alexander.
Yes, we can.
Well, thank you. And thank you to all of our incredible presenters that joined us today. Thank you to the group for hosting this presentation. And thank you to everyone here for such incredible questions and comments. I've so enjoyed watching and reading your comments. Your certificate of attendance will be emailed to you as soon as we conclude this webcast, but you can get in touch with us if you have any questions or concerns. In terms of registering for the next webinar, we've put that up in the chat, but you can always find it at the CASW webinar page on our website. So thank you to everyone. Thank you to our webinar presenters, and we can't wait to see you for the next webcast.
Thanks so much, Alexander.
Excellent.
Take care,
Thanks so much, Alexandra, and thank you.